Hello, I'm Manoj Karmakar. Welcome to issps TV. If you like any of our videos, do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notifications of any future uploads.
Hi, so we've got several questions from the Q&A box. So Dr. Ronel Nogi would like to ask your opinion on performing multi-level thoracic paravertebral block for breast surgery. So he'd want your opinion on doing multiple single levels from T2 to T4, T6, T2 to T6, every single level paravertebral block versus only doing T2, T4, and T6 paravertebral block instead. What would be your comment?
I think you should come, all of you should, if you are really interested in the topic, you should come for the webinar that has been specifically designed for this. I think it's webinar number 9, if I'm right. But anyway, to answer your question, with ultrasound guidance, we no longer do every individual injection. The evidence to show that a single injection can produce quite extensive paravertebral spread. That may not necessarily be because of paravertebral spread. Some of it is contributed by the epidural spread. So if you inject a very large volume into a paravertebral space, it has to escape somewhere, and the epidural space provides a easy pathway for it to spread. So therefore, you can get extensive ipsilateral spread, as Dr. Opal and the group from London, Ontario demonstrated. But to be able to use that consistently every day, Monday to Sunday, I think in my experience, I don't think it will be consistently possible. So we need to do multiple injections when you're doing surgical anesthesia. So what we also do, as you have asked, we perform injections of T2, T4, and T6. Now, you may say, what about T1? Actually, T1, the evidence would show that there is no contribution of T1 to the thorax. There's no dermatomal elevation of the thorax, anterior thorax, that comes from the T1. There's some contribution posteriorly, but the breast, one of the innovation of the breasts comes from the intercostals, and they come from T2 to T6. So we do T2, T4, and T6, and we divide the total injected as 7 to 8 mils at each individual level, and that usually provides extends this multidermatomal ipsilateral anesthesia that we use for paravertebral block for breast surgery. But the question is to you is, will this provide adequate anesthesia? The literature suggests that it does, but actually our clinical experience over more than a decade is that it does not. Initially, I used to think that maybe some of my paravertebral blocks are not working because we were doing it with Landmark. But more recently, we have been using ultrasound, using the articular process window, and we find that despite good pleural evidence of pleural displacement, other surrogate signs that tell you that your injection is in the correct location, but still patients, 80% of patients report. And this is actually supported by the paper by Dr. Patnaik and the group from the All India Institute. They also reported 80% of patients will report pain when you do supramammary dissection, axillary dissection, maybe lower intercostal dissection, etc. So why this happens is easy to understand, because these are afferent nociceptive fibers that are not blocked by the paravertebral block. And how do you block this in order to provide surgical anesthesia? We have achieved that, and we will share that experience with you when you join us for that particular webinar. Thank you for your question.
Okay, thank you. So another question from an audience is, what type of needles are used for different types of paravertebral blocks?
That's a very good question. I think, as I alluded to, visualizing the needle with a transverse scan is quite challenging because the angle of insertion is quite steep. Although I don't use the technique anymore because I find the transverse view quite, because it gives a very good view of the entire paravertebral space, including the the associated relationship, like the relationship of the pleura, the ligaments, where the articular process is. So you get a better three-dimensional conceptualization of the anatomy with a transverse view. Even with the transverse view, ordinary needles are sometimes quite difficult to visualize because now we are using low-frequency transducers. Often these transducers rely on compound imaging, and with compound imaging with multi-beam, where you are getting a summated information on your screen, it can be difficult to visualize a needle. So we use echogenic tip needles for these purposes, and we have found that echogenic needles are quite satisfactory. I know of many of my peers who use larger needles like 18-gauge Tuhi needles to perform paravertebrals, because bigger needles give you bigger visibility or better visibility. But I think bigger needles also cause more pain. So as a trade-off, I use 22 gauge. There are 22 gauge echogenic needles, and there are many that are available in the market today.
Okay, thank you. And then we've got some questions about the recommended dosage and volume and concentration of local anesthetic for a paravertebral block, and one specific question about any recommendation on the maximum dose of lidocaine before hypotension will occur when performing paravertebral block.
Firstly, I think if you use a paravertebral blocks, hypotension is very rare, even with extensive ipsilateral anesthesia. The ipsilateral sympathetic blockade very rarely produces hypotension. But having said that, this usually doesn't happen in awake patients because they are able to compensate for it. But sometimes when you use it in combination with general anesthesia, you will see that the blood pressure will tend to drop more than what you would normally see with a normal general anesthetic regime that you often give with induction and maintenance. But this is very easily treated with vasopressors, etc. Now, from a dose recommendation, if you're doing a single injection, we don't inject more than 20 to 25 mils total volume into a single level. That is based on our experience from landmark techniques. It is also based on our experience of pharmacokinetic studies that we have done. That these, if you say 25 mils, 125 milligrams of bupivacaine or ropivacaine, this produce fairly low concentration that are below the threshold for toxicity. But having said that, often you may find the odd patient who will say, I feel a bit lightheaded, and the typical signs of prodrome of a toxicity, etc. But they will not develop toxicity. They may also sometimes develop some myotonic kind of activity, which is it is not conscious, it's subconscious, very transient. These are all indicative that the plasma levels are high. Now, in our pharmacokinetic studies, we have shown that the absorption from the paravertebral space is like giving intravenous drug. Now, this was all done by some kind of modeling related to IV pharmacokinetics of ropivacaine. We use paravertebral ropivacaine, but we found that the peak levels that developed were quite similar to what you would get if you gave them at the same rate the infusion intravenously. So remember that in absorption from the paravertebral space is very rapid, and high levels can develop. So intercostal spaces may not always be the space that has the highest absorption rate. Paravertebral is also very vascular. The use of epinephrine or adrenaline in 1 in 200,000 reduces the absorption. So we, in my practice, in my unit, we often always add adrenaline to the injectate for two reasons. One is occasionally you may find that it may be your indicator of intravascular injection, but we rarely see it in our practice. But nevertheless, to reduce the absorption and reduce the potential for toxicity, adding epinephrine is advisable. So that would be my answer to your two questions. Any other?
So we've got one more. We've got a question from Dr. Pestari Sukhmono to ask for your suggestion in the position of doing the scan. Lateral decubitus versus sitting upright position, and if lateral, then whether or not it's better to do it on the dependent side or the non-dependent side.
Good question, Tokumono. Yeah, as you can see, doing it in the lateral position is quite comfortable for the patient. Plus, so when you do multi-level injections, we often sedate our patients. So having a sedated patient in the sitting position is not desirable. So if you're using it for multi-level or even for single level, I find lateral position is my choice. But there are times when patients may be very large, very big, then putting them in the sitting position is what I would do. But generally, average Indonesian patient like yours or my patient in Hong Kong, we find them sitting, put them in the lateral position. But when you have them in the lateral position, it is important to have the ipsilateral arm away. So you pull it away as though it's hanging out from the other side of the bed. What this does, it makes this paravertebral area, which is medial to the scapula, much wider. So you get a good area of this. So this is why, and then if your patient is sedated, with the neck slightly flexed like so, you can see I've just laid like that. And then we usually start some oxygen in a nasal cannula, 2 liters, and we sedate them with, we induce sedation with midazolam, 1 or 2 milligrams, and we give them 10 to 20 milligrams of ketamine while we perform the three-level paravertebral injection. And with that, they usually don't recollect having had the injections. When you question them sometimes, or you quiz them in the recovery room in the PACU. So it's quite comfortable for most patients. And for performing the blocks, I think it would be advisable to do it on the non-dependent side, because on the dependent side, you will have a problem with visualizing where you're inserting the needle, as opposed to if you had it on the non-dependent side, then you are directly seeing the top end of the transducer, and it's much easier to place the needle at the center of the probe, where usually the plane of the imaging is located. So I usually do it lateral, but on the non-dependent side, because that's obviously this is a unilateral block. So you should do your timeout properly, because you may sometimes place it in the wrong side. I admit I have done one paravertebral block many years ago on the wrong side, on the other side of the operation. So remember, these are unilateral blocks. So it is possible for you to, if you're not careful, to do it on the wrong side, which will be totally useless for a breast patient. So timeout is an integral part of our practice. And once we do the timeout, which is usually marked on the patient's back, we position them lateral, like in this lateral decubitus, with the arm extended out a little bit towards the other side, so that you are able to have that whole area exposed. So I hope that addresses your question, Mono.
Mm-hmm. Okay. So another question from Dr. Kenichi Matsuno. So they're wondering whether or not you have ever experienced seeing patients whom you couldn't find any interlaminar space with ultrasound for epidural anesthesia.
Hello, Kenichi. Nice to hear from you, and hope you will continue to join our webinars. Now, Dr. Matsuno asked this very interesting question, because yes, if I said I had never seen a patient where I couldn't identify an interlaminar space, I would be lying. Or maybe I wouldn't have done enough of this. It is not uncommon in the elderly, sometimes when you do thoracic epidurals, that it's very difficult to visualize the anterior complex. Now, I often treat the anterior complex as my friend, because if I can see the anterior complex, then I know there is a space. And you can imagine in the lumbar region, the anterior complex is quite wide. So the width of the anterior complex tells you how wide the interlaminar space is. And because the mid-thoracic region, the interlaminar spaces are quite narrow inherently, with age-related changes, with ossification, with pathology, etc., these spaces can become narrow. And also with age, there is loss of vertebral height, that is the loss of intervertebral distal width, etc. So the intervertebral space inherently become narrow. So the interlaminar spaces are narrow. But for an experienced individual, if you can see a small interlaminar space and you know where the opening is, I think your experience, and I know you are experienced, your experience is all that you need to identify the epidural space, because You just want to find this, where is that possible opening, and then you can guide your needle through that. Now, there are times when you may not be able to do it. In that case, my advice to lesser experienced people is always look for the lower thoracic epidural if you want, because lower thoracic epidurals are much easier to perform. They are wider spaces, and you will, by and large, be able to place. But then you have to tailor your dose and volume requirements for the patient to achieve that segmental block. So yes, in some patients, you may not be able to see the interlaminar space.
Okay. We've just got some other questions about the surgery, like regional anesthesia for breast surgery again, which I think we can wait till webinar 8 to answer that.
Yes,
And
I think so. I think all breast-related discussion we can have in that webinar, and we will do again a lot of demonstration or in videos, etc., specifically focused to providing anesthesia and analgesia for breast surgery. So stay tuned.
Okay.
Are we with it? Is that all, Roshini?
Yeah, I think
Okay.
we've asked most of the questions.
Okay. As they say in YouTube, you don't have to ring the bell here, or you don't have to subscribe to this channel, but I like to welcome you to this webinar once again when we come back again in a week's time, right? So we will be back in a week's time. So this will be rather than 2 weeks. I made a mistake, so never mind. We'll be back in a week's time. I like to see all of you back again for more excitement. Particularly, we are going to do difficult spine, scoliosis, etc., etc. So do join us again. I take this opportunity once again to thank Ranjit here, our people behind the scene, particularly Brian, Winnie, and Rossini over there, who has done a great job to collate all the questions. And I hope you had a great time. So with these few words, I like to say bye-bye for now. Stay healthy and stay wealthy. Take care. Bye-bye.
Thank you.
Thank you.